Hi, good afternoon. My name is Dr. Sheri Gibson. I identify as a geropsychologist. And I want to thank my esteemed colleagues, Dr. Qualls and Dr. Starr, who talked about not only the workforce, but also the challenges in our long-term care facilities. What I want to talk about with you is addressing two of the biggest, I think, clinical needs, mental health needs of older adults and their families. And those two things are suicide and trauma. And I want to give you a couple of statistics because I think that's important to put some meat on the skeleton. The suicide death rate in Colorado as of 2017 is 21.1 per 100,000 population. It places Colorado at the 9th highest state of all the 50 states. Suicide is disproportionate among older adults as they comprise 14.5% of the population, but complete almost 18% of all suicides. The highest rate of suicide in the U.S. is among those persons 65 years or older. Suicide rates are particularly high among older men, especially older white men, with rates higher than any other group. Older adults are less likely to report their suicidal thoughts compared to their younger counterparts. And older adults are also more likely to die from a suicide attempt than younger adults, and this is a lethal combination. Many risk factors for suicide, just so you know, for older adults have been clearly identified. For example, the accessibility to lethal firearms, lethal means, health problems and chronic pain, depression, social isolation and loneliness, health problems, chronic pain, depression, feeling like they're a burden, feeling like a person is a burden to their family. Many of these risk factors are modifiable and amenable to psychosocial intervention if those resources are available. One point I want to highlight around suicide is that it's largely preventable. The key first steps are thorough screening and assessment for those older adults most at risk, followed by appropriate psychological and pharmacological interventions to support their health and safety. Now, I heard some testimony about early childhood trauma and the effects that has across our lifespan. We know that adverse childhood events, for those of you who are familiar with the ACEs measure, that for people who do not have one adverse childhood event in their life, the attempt for suicide is 1 in 86 attempted suicide. People who endure 7 or more adverse childhood events, 1 in 5 attempt suicide. Perhaps the most important takeaway from a limited body of knowledge accumulated to date is that trauma among the elderly needs to be understood in developmental terms. Just as childhood trauma can delay or stunt early development, we need to explore elder abuse and other trauma that manifests later in life as a similar framework. There are indications that PTSD, for example, is expressed somewhat differently in older adults and has been described as a form as accelerated aging even. Deficits in attention, memory, and executive functions, altered stress hormone levels, and changes in brain structure can happen as a normal part of aging, but can occur sooner and more extensively among older people coping with a trauma. And these effects of trauma, disorganized or agitated behavior, faulty memory, even self-neglect, can be confused with normative cognitive decline. As a result, for many older adults in need of help and healing, the root cause of those difficulties and troubling behavior is not understood, nor is it addressed. There's a role, I believe, for everyone to play in making organizations, systems, and communities more attuned and responsive to the elders who are suffering in both mind, body, and spirit, and in heart, as a result of abuse and other traumatic experiences. Fundamentally, providing trauma-informed care is to older survivors of abuse is about supporting healing and hope among people who may have years more to live and much more to give. In 2018, in October of 2018, there was a task force created by the Weill Cornell Medicine's New York City Elder Abuse Center and the Harry and Jeanette Weinberg Center for Elder Justice at the Hebrew Home in Riverdale, at the Weinberg Center in Riverdale, New York. And they convened experts across the country with experts who had deep knowledge and experience in subjects spanning neuroscience and geriatrics, innovative trauma therapies, and public policy to begin answering an overarching question that I present to the state behavioral health task today and to all of us. The question is, what do professionals across disciplines and systems need to know about trauma and its effects on older adults to be able to identify individuals in need and help them heal? We have an opportunity to provide a corrective emotional experience for people who have suffered trauma across a lifespan. We are at a critical moment, I believe, to be able to do that effectively and with heart and compassion. And so I would emphasize that we adapt trauma-informed care approaches and training across all care settings so that we can meet people where they are and give them a healing experience that happens only in relationship. And those relationships we have the ability to change and transform. Thank you.